Hello, and welcome to another episode of Craig International on the Go. I'm pleased to be joined by Dr. Gregory Furman. Today we're talking about severe bleeding associated with vitamin K antagonist.
We've referred to vitamin K antagonists. It's more commonly known in the U.S. anyway as warfarin. And specifically, let's talk a little bit about how you manage bleeding in a patient that is therapeutically anticoagulated on a vitamin K antagonist or warfarin. First of all, I'd like to introduce the concept of factor repletion rather than reversal. I think we commonly think that we can reverse the INR or somehow reverse the bleeding in vitamin K antagonist treated patients. But in fact, what we're trying to do is give them factor back that is poisoned from their use of their warfarin. So we're really talking about repletion of the vitamin K dependent factors, which are factors 2, 7, 9, and 10, along with protein C and protein S. So any way that you can do that will be beneficial in terms of the bleeding patient, because warfarin has such a long half-life of over 40 hours. You really have to embark on a strategy to give the patient back what they lack, which are the vitamin K dependent factors. It takes the liver over 24 to 48 hours to manufacture these or to synthesize these in the liver. So it's important to kind of to give them agents that might actually help them. You can also use packed red blood cells in a patient that's hemodynamically unstable and platelets as necessary. But the first order of business with vitamin K antagonist treated patients is to give them vitamin K. Now you can give that orally, but preferentially parenterally if they're having acute hemorrhage. So vitamin K, 10 milligrams IV, followed by more commonly and more historically fresh frozen plasma, which has factors 2, 7, 9, and 10 along with protein C and protein S. The trouble with fresh frozen plasma in this scenario, Brian, is that it has a lot of colloid. It's 250 milliliters of colloid per unit of FFP. And it doesn't take much to cause volume overload in a patient that might have an impaired left ventricular function, such as a heart failure patient or a renal failure patient. And each unit of FFP only has about 2 to 5% of the clotting factors that you're going to need to give back to your patient. So you're going to have to give a fair bit of it, upwards of 1.5 liters of FFP. In addition, the limitations are that there's time to thaw these units. They have to be cross-matched. There's transfusion reactions, and although low, infections are a possibility. So because of these limitations, there has been developed 4-factor PCCs, otherwise known as K-Centra, which has a strategic advantage to FFP in this scenario. It's been shown to more rapidly reverse anticoagulation with vitamin K antagonists. It's dosed based on the INR with 25 units per kilogram if the INR is 2 to 4. For INRs of 4 to 6 at 35 units per kilogram. And for those that are 6 or greater, get 50 units per kilogram. And the volume considerations are not a factor. This is a lyophilized powder that is reconstituted. So what do we know about the use of FFP versus 4-factor PCCs? With respect to major bleeding, what we do know, it has more rapid INR reversal and more clinically relevant hemostasis than FFP. And with respect to urgent surgery patients, studied recently as well, again, more rapid INR reversal, more clinically relevant hemostasis in the two subject populations compared between K-Centra and FFP. So certainly represents a strategic advantage over our current therapies.
Well, thank you very much, Greg. Well, this is really important to know, because historically, agents such as Coumadin were classically used to treat patients that needed anticoagulation. Well, it turns out that those have significant potential morbidity and mortality. So understanding what Dr. Furman just said as far as how do you treat those patients becomes critically important. Thank you very much for watching Craig International on the Go.